Welcome, everyone. My name is Ivory, Allison, and I am the National Director of Community Impact for the American Liver Foundation. The American Liver Foundation is the nation's largest nonprofit serving people with liver disease, where we provide a voice and an ear for people with liver disease and their families through education, support, research, and advocacy. In partnership with the Centers for Disease Control and Prevention, the American Liver Foundation is proud to host this webinar, Hepatitis C Virus, Barriers to Treatment and Community-Focused Primary Care, for liver specialists and public health providers. We will share recent data indicating that too many Americans remain unaware of their hepatitis C infection and treatment continues to be delayed. We will also discuss adult screening recommendations and strategies for addressing gaps in viral hepatitis care. Today's program will be recorded and shared on our YouTube channel. To ask a question or for general comments, please use the chat button. Our presenters today are Dr. Carolyn Wester, the Director, Division of Viral Hepatitis, National Center for HIV, Viral Hepatitis, STD, and TB Prevention, Centers for Disease Control and Prevention. Dr. Andrew Seaman, the Medical Director of Hepatitis and HIV Services, Central City Concern, and Associate Professor of Medicine at OHSU. Dr. Behnoosh Momin, the Health Scientist, Division of Cancer Prevention and Control, National Center for Chronic Disease Prevention and Health Promotion, Centers for Disease Control and Prevention. And Katie Jones, the Manager of the Comprehensive Cancer Control Program at the Iowa Department of Health and Human Services. And I am thrilled to welcome Dr. Emmanuel Thomas, Associate Professor, Pathology and Laboratory Medicine at the University of Miami Miller School of Medicine and the Board Chair for the American Liver Foundation, who will moderate our Q&A. And please save the date for two of our fall programs, the Educated Patient and Liver Cancer Conference on October 21st, and our 32nd Annual ARIA Symposium on November 16th. You can find more information on our website at liverfoundation.org/events and follow us on social media. I would now like to begin our webinar with Dr. Wester.
Thank you very much. It's a pleasure to be with you this afternoon. I have the opportunity to provide an update regarding hepatitis C and the opportunities and barriers that exist regarding access to life-saving treatment. Next. I'm sure as this audience is familiar, hepatitis C is a public health crisis in the United States. Over 2 million people, recent estimates indicate, are living with hepatitis C in the US, despite the fact not shown here that estimated 1.2 million people have been treated with direct-acting antiviral therapy for hepatitis C from 2014 through 2020. Updated prevalence estimates show that we are relatively at the same prevalence level. 1 in 3 people with hepatitis C remain unaware of their infection and therefore unable to receive life-saving treatment. On the left, you can see that rates of acute hepatitis C infections continue to rise in most age groups. The overall rate has increased 300% over the last decade, or quadrupled, and rates are highest among reproductive age individuals 20 to 39 years of age. Not shown here, but the increasing acute rates among reproductive individuals threaten a trimodal curve of perinatal infections as well. Currently, we're seeing on the bottom right, given that more than half of acute infections progress to chronic infections, a bimodal curve showing that hepatitis C is now heavily affecting multiple generations. Next. Without treatment, hepatitis C can lead to liver damage, liver cancer, and death. Fortunately, highly effective, short-acting, oral only, 2 to 3 months of treatment can result in a cure in more than 95% of individuals. The cure also results in a 70% reduction of new cases of a hepatocellular carcinoma. The direct-acting antiviral treatment is cost-saving. Public health and economic considerations support widespread and unrestricted treatment of Hep C. Next. Yet, recent analyses show that we are still leaving many people untreated. This vital signs report, released in August of last year, looked at a cohort of individuals who were diagnosed with hepatitis C and continuously insured in 2019 and 2020. Of those individuals, 1 in 3 initiated direct-acting antivirals within 1 year of diagnosis. It's important to note that uninsured individuals were not included within this cohort, and that of those who did start treatment, the vast majority started within the first 6 months. The treatment coverage rates were even lower among Medicaid recipients at 1 in 4. And when we looked at Medicaid recipients across various jurisdictions, we saw further reductions among Medicaid recipients among those living in states with at least one eligibility restriction and with a race other than white. Next. This analysis highlighted some of the barriers on the left. In order to overcome those barriers, we recognize that we need to implement universal hepatitis C screening recommendations recommended since 2020 by both USPS Task Force as well as CDC, recommending one-time screening of all adults and pregnant persons during every pregnancy. And that was subsequently endorsed by the American College of Obstetrics and Gynecologists, as well as the Society for Maternal Fetal Medicine. As the data was shown on the prior slide, we need to remove eligibility restrictions and burdensome prior authorization requirements for hepatitis C treatment. We need to make sure that treatment is provided where people receive other services. We'll hear a little bit more about that later today, and expand the number of primary care providers and substance use disorder treatment providers providing treatment, again, where people receive services. Next. We have seen progress in the removal of eligibility restrictions as well as pre-authorization requirements. This has been followed by a number of years with the National Viral Hepatitis Roundtable, as well as the Center for Health Law and Policy Innovation at Harvard, who have been publishing and analyzing Medicaid report cards for states for a number of years now. As of earlier this year, 20 states and DC had removed pre-authorization requirements. This is a great step forward, but more than half of states continue to impose prior authorization restrictions. Next. As I mentioned, we have ample opportunities to increase hepatitis C testing and treatment. These are just some of those, and include decentralizing and integrating simplified and routine Hep C testing and treatment into primary care settings where people with hepatitis C receive care. That includes providing treatment in non-traditional healthcare settings, such as fringe service programs and other decentralized settings. We need to promote holistic drug user health, including a menu of prevention and treatment services, integrating addiction treatment along with infectious disease diagnosis and prevention and treatment. CDC is working on a number of different fronts in these areas. Certainly, we work with our health departments. We also work with academic and community-based organizations. We are providing training and education, subject matter expertise, and promoting opportunities for policy change to support hepatitis C elimination. Next. We often hear in the community that providers are reluctant, or even decentralized service providers are reluctant to test if they don't know where to refer someone to treat, if they don't have co-located services available at that point. And I just want to draw attention to a Hep C treatment locator widget. It is available online. It is an opportunity to just enter a zip code to find a Hep C treatment provider nearby. Providers similarly can add their information into the widget as well. and it can be easily embedded onto partner sites. And I will close with the next slide, just on an exciting note, to raise awareness and draw attention, if you're not aware already, of a wonderful proposed initiative that is not funded yet, but has the support of President Biden as part of his Cancer Moonshot, and led by Drs. Francis Collins and Rachel Florence. There's been a proposal for an $11 to $12 billion proposal over 5 years for a national hepatitis C elimination program. Updated estimates published recently show that this would be cost saving even by 10 years. 10 years is the lens that the federal government looks at in order to determine if something is cost saving or cost neutral or a net cost. So the initial showed that it would have a net cost of $5.1 billion over 10 years, but updated models, including calculations for extra hepatic savings, such as avoidance of chronic kidney disease or diabetes mellitus, estimate that the initiative would be cost saving within 10 years to the tune of about $18 billion. The initiative has 3 main pillars: accelerating the availability of diagnostics, a drug procurement program, which would provide broad access to curative hepatitis C medications across all populations, including uninsured, justice involved, and also help defray costs of some other populations. And then, of course, comprehensive public health intervention. So with that, on that optimistic note, I am going to close and turn to my subsequent speaker, but thank you very much for the opportunity to be with you. It's a very exciting time for hepatitis elimination in the US.
Thank you so much, Dr. Wester. We will now have Dr. Andrew. And you're on mute.
I'm Andy Seaman. I'm going to talk to you about harnessing the power of micro-elimination in community partnerships to end hepatitis C. These are my disclosures. So we're going to take a brief walk through the journey of the Central City Concern Hepatitis C Elimination Program, where I work, and talk about this concept of micro and macro elimination and how we might target innovations and build partnerships to address gaps in the care cascade. And finally, we're going to talk about exploring the role of love, harm reduction philosophy, and interconnectedness in Hep C elimination. So this is Oregon. This is a map of Hep C prevalence in the state. It's in 2017. The darker areas mean more Hep C. And up here in the corner is the Portland metro area where Central City Concern is located. So Hep C is a rural and urban problem, and our work is done urbanly, and I'll talk more about the rural setting in a second as well. CCC is a houselessness services organization. We provide supportive housing and other housing options for people who are living with houselessness, residential care, some culturally specific services, and some primary health services for this population as well. And so we began in 2017 with a couple of docs and just began treating Hep C. And we ran into wall after wall. At that time, the Medicaid payer in the state required you to not only have cirrhosis, but complications of cirrhosis. You couldn't use substances to be treated, and only specialists could treat. We had to receive special attention or permission. And we were also really inspired. So the first few patients that we treated would tell us about this transformative experience that it was. Hep C, while most people today who get Hep C get it through injection drug use, people don't get Hep C because they inject drugs. People get Hep C when they are in moments of extremis. So if you are sick, if you're in withdrawal, if you are in a relapse mode, if you are in some sort of intimate partner violence situation, those are the common scenarios where people will say that's when they got Hep C. And so it's not only the stigma of the virus or the stigma of addiction, it's the most compressed stigma that people have, that they've internalized and have this constant reminder when they walk through life. So when we cure people of Hep C, we are in part liberating them from some of that history. And we studied this in a qualitative study where we looked at what the impact of treatment was, and people would report, excuse me, more self-efficacy, less chaotic substance use, more harm reduction engagement, and better relationships for people who use drugs. So we started small with lots of heart, but very few systems. So this is a look at a basic care cascade. At that time, we were treating the folks in Old Town Clinic, and we were screening people who were at risk. And you look at the percentage of people who were there, who were screened, it was relatively low, around 35% or so. And about 35% of those ended up having a positive Hep C PCR or having chronic hepatitis C. And only about 41% of them were initiated on treatment in this first year, with pretty good completion of SVR12, which just means proof of cure labs. So we knew we had some issues. We knew we needed to systematize. When we first took a look at this care cascade step of everyone in our clinic and then who got screened and who didn't. And so we tried to implement, or we implemented a universal opt-out screening process. And we took it out of the hands of the providers and we gave it to non-clinical staff at the bottleneck in our clinic, which was at the point of intake. Everyone had to go through this process, and we gave them the ability to order labs and offer screening at the time of intake to services. And we also knew that not enough people were initiating on treatment. So we had to streamline the referral processes and then address this prior auth restriction. And one of the ways we did that, to the best of our abilities at that time, was to pre-review all patients, order medications in advance so that when the person shows up at your doorstep, you have the meds, you're ready to go. In this population, you cannot say, come back later for your medications. You have to give them their medications right away. So our job here is to cut out as many steps of the care cascade as possible and to streamline whenever possible. Not sure why my slides look like this here, but what we have here the next step was that we built up internally. So we added a clinic site and increased our background screening pool. And then we implemented this universal screening process, which increased overall screening from 31% to 46%. We still had this big gap of folks who were already in our clinic, and we hadn't quite figured out how to address that. So the next thing we did was we decreased treatment barriers. We worked really hard at the state level to reduce prior auth restrictions. So this is 1 year later here in 2019. And we were able to get rid of some of the substance use restrictions and decrease the fibrosis scores somewhat. So iteratively and over time, we worked on these. We got more outreach workers for better care coordination support. And we developed a new lab algorithm with LabCore that allowed us to order the Hep C screening and confirmation test. And if they were positive, it would reflex to all the other pre-treatment evaluations. So we're trying to figure out, how do we screen one time and get people ready for treatment so that the next time you see them, you give them medications. And we also found during this time, after doing these steps to lower treatment barriers, that the number of people who are coming in to complete their proof of cure labs was falling. But this is not a failure. This demonstrates that we're finally starting to treat the people who really have to be treated, the people with all of these different competing interests. Maybe they're actively using or looking for housing. People are less likely to come in to get those proof of cure labs. So we're on the right track. And overall, we had very, very little treatment failures at that time. So fast forward to March of 2023, and we now have 1,400 plus people who have in some way engaged in our services. And of those, we have approached for screening almost all of them. And one of the ways we've done this, one of the ways we have built up this screening base is by building partnerships with supportive housing, substance use treatment programs, internal and external, 3 opioid treatment programs, which are really important, lots of street outreach in other systems. So that was important to build the screening base, but we still needed new tools. Screening with phlebotomy in the field is really challenging. So we validated a test called dried blood spot, which is used in many other countries, but had not been used commercially in the States before with a partner lab, molecular testing labs. It's basically a fancy piece of paper. You poke your finger, put some drops of blood on it. And the benefit of this over, I think, even point of care Hep C RNA testing is that you not only get the Hep C RNA test, but you can also get a hepatitis B surface antigen, and we can also do a core antibody, which allows us to start treatment potentially without any additional fibrosis testing. We also started paying people some money for testing, which helps a lot. And the net effect of all of these community partnerships is that we had this big web of interconnectivity. And I cannot stress enough how important that is. If in a vulnerable population, you're going to miss people at individual points. But if you can catch them in all of these different steps along the care cascade, we can invite them back into care and get them cured. So we have, this is now just starting with the folks who are PCR positive, looking at this overall data. We have treated the vast majority of them or initiated on treatment. And much of that comes from, most of that comes from, I think, this interconnectedness and lowering these treatment barriers. But there are some other things coming our way which are not yet reflected in the data. So one of them is, now that we have the prior authorization removed, which happened just at the beginning of this year, and this dried blood spot test validated, we have created a new questionnaire, validated based on our data, and we can now ask people just a few questions and very effectively rule out decompensated cirrhosis. And so we are starting people on treatment without any phlebotomy, any FibroScan. You never have to walk into a health clinic. We're treating people in the community, in opiate treatment programs. I think it can be a real game changer. And our incentive, our SVR12 completion has gone up a little bit, despite a more complex population. And part of that is because we're paying people for these tests, and part of it is because we are using dried blood spot for some of them as well. So the last data slide I'll show you on this, on Central City, is more of a longitudinal look. Calendar years here on the bottom, 2017, 18, 19, et cetera. And the dark green line here is the number of people who are initiated on treatment in the first 60 days. The light green is treatment initiation ever. And the light blue line is PCR positivity rates for screening. So the dark green line here, you can see early on, again, we had a pretty low treatment initiation rate, and that went up pretty tremendously after getting rid of the prior authorization. It was definitely one of it, but a lot of it was these tools that allow us to remove steps of the care cascade, make sure we got all the labs, et cetera. But then you start to see these fall, both the short-term treatment and the longer-term treatment. And those fell in large part because, again, we're now getting out more and more and more into the harder to reach populations. The easier to treat folks are being treated, the harder to reach folks are harder to treat by definition. The other thing this shows you is that the people who have been diagnosed in our system, within the first 3 years, almost all of them have been treated at some point. So even though they weren't treated quickly, we were able to pick them up again, back to that interconnectedness, back to being linked in your community and being known in your community. The last thing I'll say is that this PCR positivity rate has continued to fall over time. Now, some of this was because we moved to universal screening, but then over time, we see that despite the fact that we're going into increasing complex populations who are not engaged in our health services, we still have a fall in PCR rate. I think if you were to look at our internal services, the actual prevalence would be very, very low. And so I think this is what elimination looks like. So we have to stick with it. You need those community partnerships, and you really need loving, harm reduction, focused, and philosophy staff who are out there in the field, who everyone they engage with knows that it's okay. Whatever it is, it's okay. You can always come back. And if you do that and you are consistently messaging on that, people will come and find you. So we can't owe these folks enough debt of gratitude. The last data I will show you is that this addresses an urban problem. You really can't implement this kind of thing in a low density area. So we designed a study, my colleague and mentor, Dr. Todd Korthus, and I we designed a randomized controlled trial where we took people with lived experience, peers, and engaged them in the Hep C elimination work. So going out into the community to parking lots of Bimart and syringe service programs and camps, and they're engaging people who are actively injecting drugs with Hep C into the cure. So they go out and they screen with point of care. If they're positive, they get them into all of their pre-treatment labs by a standing order, and then they facilitate, if randomized to a peer-assisted telemedicine model, they facilitate a telemedicine visit directly to a provider in Portland. They provide adherence support and medication lockers, and they help them get their SVR12 labs done. So in the enhanced usual care arm, this is the referred to local community resources versus the telemedicine arm. This is the direct peer facilitated telemedicine arm. we had a 16 versus 85% initiation rate, and that rate carried over into the SVR12 results. So we really have to rethink how we do rural Hep C treatment, and we have to rethink what we really need for treatment infrastructure. So just to summarize, start small, but don't forget the big picture. We can't do this work unless we fix the broader systems issues. Weave a wide net. The more you have tendrils into the community, the more you are loved and welcomed by the community, the more people will come back and find you. And then you can't build systems without heart or have heart without systems. So we really need both, and you really have to stay engaged and stay inspired. And removing barriers to treatment and innovation like prior authorizations. I will say this again, we cannot eliminate Hep C with prior authorizations. We cannot, they must go. All right, and then finally, peers are wonderful. They are trusted, and I cannot speak highly enough about engaging them in these systems. Thank you. I'll pass it on.
Thank you so much, Dr. Seaman. We will now welcome Katie Jones and Dr. Behnoosh.
Thank you to the Liver Foundation for the invitation. I'd like to situate in the next slide, I'd like to situate the liver cancer prevention efforts at CDC. You can see here on the left of this slide, the National Center of Chronic Disease Prevention and Health Promotion at CDC is one of 10 centers within the CDC agency, and the Division of Cancer Prevention and Control is one of 8 chronic disease divisions within the center. In the next slide, you will see our center approach to chronic disease prevention, and this falls within 4 domains. The first domain is to understand the epidemiology and surveillance. The second is to engage in environmental approaches, and the third and fourth are to implement healthcare system interventions as well as community programs that link to clinical services. In the next slide, you will see our approach taken at CDC in terms of addressing the social determinants of health. And we take a upstream approach to ensure community impact. And our objectives are to improve community conditions through a whole of government, cross-sector, community-driven activities. In the next slide, you will see our Division of Cancer Prevention and Control's aspirations, our 3 aspirations, our 3 strategic priorities, our guiding principles, as well as our strengths at CDC. And that is our data, translation and evaluation, and our partnerships. In the next slide, I will briefly speak about one of 4 national programs that are funded in our division. And this is the National Comprehensive Cancer Control Program, where we fund all U.S. states, DC, and U.S. tribal organizations, as well as U.S. territories, it's a cooperative agreement, a 5-year cooperative agreement, with the goal of implementing strategic and sustainable cancer plans and implementing those cancer plans. And in the next slide, you will see our 3 priorities of the National Comprehensive Cancer Control Program, and that is 1, to emphasize primary prevention, 2, to support the early detection and treatment, 3, to address public health needs of cancer survivors. And then we have these cross-cutting strategies, which include implementing policy systems and environmental approaches, promoting health equity, and then demonstrating our outcomes through evaluation, which then help to inform future program planning. In the next slide, you will see here on the left, you will see, while overall in the US, all types of cancers are on the decline, liver cancer incidence has been increasing in the United States since the mid-1970s. Between 2006 and 2015, incidence increased by 32% and death rates increased by 25%. Next slide, please. Our latest data that we have access to looks at data between 2015 and 2019. And you can see here that there is stable rates that we're seeing. However, there are populations of focus that we're taking a closer look at. And so you'll see here, Hispanics have the highest incidence and tend to be diagnosed at later stages with more advanced disease. Asian Americans, Native Hawaiian, Pacific Islanders have the second highest incidence based on our latest data. And individuals in this group report poor knowledge regarding the link between HBV and liver cancer. American Indians, Alaska Natives have the third highest incidence, with the highest rates occurring on the Pacific coast. And this community is disproportionately affected by HCV infections, and insufficient access to treatment for HCV infections remains a barrier for this community. And then Blacks have the fourth highest incidence, and this community often do not know that they're infected due to limited disease awareness, as well as healthcare access. So this data helps to inform a lot of our program planning. Next slide, please. The next two slides showcase the nationwide changes over time with respect to liver and intrahepatic bile duct. And this side, you can see new cancers, all ages, all races and ethnicities, and both sexes. And in the next slide, you can see the cancer deaths between 1999 and 2019. And so it's clear that liver cancer prevention efforts at CDC is a key priority for us. Next slide, please. In 2010, the National Academies released a national strategy for the prevention and control of hepatitis B and C, and made recommendations for 4 areas of work that we should be engaged in. And that includes improved surveillance, improved knowledge and awareness of hepatitis B and C virus infections, improved immunizations, and the improved delivery of viral hepatitis services. Next slide, please. So CDC began our first demonstration project between 2015 and 2018. And this is with the Cherokee Nation Health Services, as well as the Comprehensive Cancer Control Program and Idaho's Department of Health and Welfare. And we engaged in a partnership with them and published our findings in 2 journals, Preventing Chronic Disease and Health Promotion Practice. And a lot of the work incorporated work that were earlier described with respect to the Hep C elimination program and education around the risk between disease, risk factor and disease. Next slide, please. We also developed an action plan where we're able to promote or disseminate to other cancer control programs and hopefully scale some of our interventions. And you'll see in our next slide here that prior to the pandemic, there was a population that we were looking closely at, and these are people who inject drugs. And we know they have an increased incidence of bloodborne infections, including viral hepatitis, and that these infections are spreading through using and sharing contaminated injection drug equipment, unsanitary conditions, and even low vaccination rates. And these infections have been increasingly impacting Americans, not only in the rural, suburban areas, as well as the urban parts of the country. But we know here at CDC that infectious disease programs work in community settings to stop the spread of infectious diseases like HCV, and that access to comprehensive prevention service is essential for this population. Syringe service programs are these community-based prevention programs that do provide a wide range of services. And 30 years of research show that these programs are safe, they're effective, they're cost-saving, and they reduce transmission. But Katie Jones will speak a little bit more of some of our barriers and challenges with respect to that. On the next slide, you'll see that we then engaged in our second demonstration project with 4 programs. And I'd like to turn it over to Katie with the Iowa Department of Health, who will present on some of our work specifically in Iowa.
Great, thank you. Thanks for having me. So I will be presenting about a demonstration project that was done in Iowa. And first, I'm going to provide some background information, then a project description, and finally project achievements. I'm going to try not just read the slides and stay within the 10 minutes, so I may not cover everything on each slide. As discussed earlier in the presentation, opioid use has increased in the US, especially among those ages 18 to 39. In Iowa, 86% of Iowans under 40 that have HCV are non-Hispanic and white, and 59% are men. There are a number of prevention challenges in Iowa. These challenges include that syringe services programs are not legal to operate. There's a limited number of harm reduction organizations with low capacity and support. Iowa received a D rating related to Medicaid restrictions to access for treatment, and there's limited funding for treatment for the Department of Corrections as well. Again, just to reiterate, Iowa is just one of 12 states where state law does not allow for the operation of syringe services programs. HCV and HCV can cause liver cancer. In Iowa, liver cancer incidence and mortality are on the rise, just like was noted for the US too. Iowa also has that trend. So we, Iowa HHS, we were selected by the CDC to engage in a liver cancer demonstration project. We partnered and subcontracted with the Iowa Primary Care Association, which serves federally qualified health centers or FQHCs across Iowa. The project primarily focused on the following strategies. The first one being provider education regarding the link between the opioid crisis, increased rates of viral hepatitis, and liver cancer. And the second strategy was improving the delivery of viral hepatitis services. Across Iowa's 13 FQHCs and one migrant health program, the majority of patients are at or below 200% of the federal poverty level. Approximately half are covered by Medicaid. 21% are best served in a language other than English, and many are experiencing homelessness. Data shows persons experiencing homelessness have higher rates of Hep A, HCV, and HCV, and an increased number of social determinants of health, leading to health disparities related to hepatitis, as well as other disease categories, including mental health. This is just a map that shows the locations of the FQHCs across the state of Iowa. And as you can see, some are in more metro areas and then some are in more rural areas as well. To implement provider education, our demonstration project was an ECHO, which stands for Extension of Community Healthcare Outcomes. It's a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. At the onset of this demonstration project, the Iowa PCA had 2 ECHO series already in operation, the HCV ECHO and a medication-assisted therapy MAT ECHO. These ECHO clinic telemonitoring mentoring opportunities are open to a wide array of healthcare staff. The MAT ECHO transitioned to a behavioral health ECHO in January of 2021. The behavioral health ECHO was similar to the MAT ECHO, however, but the target audience encompassed a wider audience, including behavioral health providers across all levels and primary care providers. So each ECHO consists of an ECHO coordinator, a panel of subject matter experts, aka the hub team, ECHO participants, which are also called the spokes, and participants. Each ECHO model is formatted to include 30 to 45-minute didactic on topics relevant to the ECHO focus area and 30 to 45 minutes for spoke participants to present patient cases to peers and the hub team. The ECHO clinics are facilitated by the Iowa PCA Director of Clinical Consulting and Behavioral Health Consultant, who completed the University of New Mexico Project ECHO training. Case presentation facilitation is led by the hub team lead, which is a trained professional relevant to the ECHO. The HCV ECHO hub team is co-led by a hepatologist and infectious disease specialist, and the behavioral health ECHO hub team is led by a psychiatrist. Iowa Medicaid restricts the prescribing of HCV treatment by requiring all HCV treatment to be prescribed, quote, by or in consult with a specialist. So the HCV ECHO allowed primary care providers to present their patient cases to a hub team, which consisted of a hepatologist, infectious disease specialist, pharmacist, and licensed independent social worker, and allowed the primary care provider to review their proposed treatment plan with identified specialists, which met Iowa Medicaid prescribing prior authorization requirements. For our evaluation, these are some of the key results. During the project period, there were 8 unique sessions held. The results were evaluated through a pre-post survey. The survey collected information, including related to knowledge about this topic and the ability of providers to speak with colleagues and at-risk patients regarding opioids, viral hepatitis, and the liver cancer connection, identify patients at risk for liver cancer, refer at-risk patients for screening and vaccination as well. Iowa PCA also collected data to track the number and types of cases that were presented and the courses of treatment recommended. So this slide shows some project achievements, including that 250 providers, which that number is not all unique, participated in the 8 live sessions. Regarding achievements for the second strategy of improving the delivery of viral hepatitis services, 99 cases were presented across all 8 sessions. All had chronic HCV and 52 unique providers participated in those. An average of 7 cases were presented during each HCV ECHO session. This slide shows some of the demographic information about the cases. Most were non-Hispanic, white, and male. This table shows the number of HCV screenings completed at the 11 health center sites participating in the opt-out screening grant through Iowa HHS and the Iowa PCA. The data reported monthly by the health centers is aggregated data and compiled quarterly into the number of patients seen during the quarter who are eligible for screening, number of rapid point of care tests completed, number of conventional lab draw tests completed, and the number of positive results. Opt-out HCV screening is based on the CDC and U.S. Preventive Services Task Force screening recommendations. And I know I'm going through a lot of slides very quickly, so I'm sorry I don't have more time to dive into a lot of this. This one shows some of the successes that we had. The expansion of the MAT Echo to behavioral health was a success because, as was addressing the Iowa Medicaid restrictions to treatment, participation among the Echo clinics remained steady throughout the project period, despite the challenges of COVID during the project period. This project overlapped with a lot of the COVID-19 pandemic. Some barriers are on this slide. So there were a number of barriers, including competing priorities among the providers, data collection challenges, and challenges related to serving the FQHC population. Some additional barriers included that the content of the didactics was repetitive by the end of the project period. It's challenging to ask the presenters to include content that's not theirs to their presentations. And also methamphetamines are actually more prominent in Iowa, but the focus was on opioid use for the project. So that was just something else to consider. And then finally, I just want to plug that the Iowa PCA continues to offer both the behavioral health and HCV Echo, and you can sign up for them if you're interested. There's information on how to register on this slide. Thank you.
Thank you, Katie. So where do we go from here? Based on the data we have from 2019, which is the latest data here at CDC, liver cancer is in the top 10 cancers by rates of cancer deaths in the US. And in 2016, the 21st Century Cures Act funded the cancer moonshot, and President Biden reignited the cancer moonshot, as Dr. Wester had mentioned, but the goal of reducing cancer deaths in half in the next 25 years by taking a whole of society approach. And so there have been some exciting achievements, and Dr. Wester had mentioned one, that specifically the National Hepatitis C Elimination Program. Dr. Francis Collins published a paper in JAMA calling for funding for the National Hep C Elimination Program. The National Institute of Health, NCI, National Cancer Institute, just last month released a national cancer plan. Many of those 8 priorities or goals within those plans are work that CDC programs here in the Division of Cancer Prevention are already engaged in. And a study last month was also published by the NIH that calls for acceleration of progress to achieve the cancer moonshot goals, and liver cancer prevention has a role to play. As Dr. Wester mentioned, there was a specific area to looking at implementation efforts, and Katie gave a good example of just one of our collaborations with the state of Iowa in the type of implementation efforts we're involved in. In the next slide, I'd like to quickly present some of the research to support public health practice gaps. So we know that the research suggests that public health increases the likelihood of success in meeting our goals when we're routinely engaged in partnerships and these multi-sector approaches, which then also serves as a key premise to meeting our social determinants of health objectives in the Healthy People 2030. We know that research supports the need for public health departments to provide important data to their local and state constituents. We know, as Katie mentioned, Project Echo has been a global change organization and has been empowering underserved communities. It's demonstrated the efficacy and the sustainability of the Echo telementoring model, which we hope to leverage with other programs. And we know there is not good public awareness about hepatitis B. Next slide, with respect to hepatitis C, in the United States, about 75% of the new HCV infections are caused by injection drug use. And we know that this year, CDC published updated recommendations for HBV screening and testing to include screening, universal screening. And then the burden of liver cancer is steadily growing because there are these emerging risk factors. So obesity, type 2 diabetes, and non-alcoholic fatty liver disease, which are replacing viral and alcohol-related liver disease as major pathogenic promoters. We also know that communication-related issues may play a role in the disparities, and the need for public health departments to assist with the evaluation of health outcomes for us is important at CDC because it helps to inform future public health planning. So in the next slide, the question for us is, how do we do this? We need an all of government, all of society approach to this. We hope to continue building on our work in these areas. We know partnerships are critical. We hope to share our best practices and our lessons learned. And we hope to adopt these strategies to other cancer control programs and disease prevention programs, really looking at those populations of focus, taking a research to practice approach, developing solutions to address these barriers, and of course, staying abreast of these emerging trends that are contributing to the liver cancer incidence and death rates. And I just want to end by thanking and acknowledging our team, and that's the ICF team. And on the next slide, I've listed the 7 award recipients that have been selected and has supported all of our work. Thank you.
Thank you so much, Katie and Dr. Behnoosh, and to all of our presenters. I will now ask all of our presenters to turn their cameras on, and we will have our Q&A session that will be moderated by Dr. Thomas. If you have any questions, please post in the Q&A. We know a few questions were answered, but so that everyone can hear the answer, we will review those questions again and answer them so everyone can hear them. So I will now turn it over to Dr. Thomas.
Thank you, Ivory. First, I want to thank all of the speakers who are acknowledged leaders in their field, and American Liver Foundation is very thankful for your time and contribution to this event. I do want to mention that American Liver Foundation is committed to erasing stigma that is associated with liver disease and many of the comorbidities that you've heard about today. And also, American Liver Foundation is committed to working with organizations like the CDC to eliminate all viral hepatitis, including Hep C, Hepatitis B, and Hepatitis D. So with that, I wanted to start the Q&A with one of the exciting events in the field, which is the National Elimination Plan. There were several questions in the chat asking for details. This webinar wasn't specifically focused on the elimination plan, but I'd like Dr. Wester to spend some time to give us some more details and maybe specifically address some of the questions related to the National Viral Hepatitis Elimination Plan.
Great, and please, Dr. Thomas, direct me specifically if there, I'll start, and then if there are certain questions that you want me to address, and I haven't, please let me know. But yes, the elimination plan, the 3-pronged proposal, which is in President Biden's budget, would not become law until it gets passed by Congress. So right now it's in the president's budget. It is proposed at about $11.5 billion initiative over 5 years to meet 2030 hepatitis C domestic elimination goals. It has 3 pillars: advancing diagnostics, so an investment in discovery and approval, not only of diagnostics, particularly point of care, RNA diagnostics or viral diagnostics, but also a drug procurement program, which would provide unfettered access to direct-acting antivirals for uninsured and underinsured populations, and then also comprehensive public health implementation. And of course, the pillars of public health implementation include everything from the testing to the linkage, navigation to cure and treatment, the technical assistance provided across settings to make sure that not only providers are trained, but that there's task sharing, that there's technical assistance for establishing co-located services or smooth, rapid linkages. And then of course, prevention services. We have emerging opportunities within perinatal aspects. And then also we recognize that with folks, in order to reduce prevalence, we have to reduce incidence as well. And then of course, data. So comprehensive data, not only outbreak detection and response, but data to monitor progress and inform public health programs. So CDC is obviously a leading implementation partner with health departments and also community-based organizations, but there are other key implementation organizations within the federal government too, which includes, and is certainly not limited to, HRSA, the Bureau of Primary Health Care, Indian Health Services, etc. So I'll leave it there for right now.
Thank you, Dr. Wester, for that overview. There are specific comments on what will happen if the funding is not approved. And Dr. Wester, I'd specifically like you to talk about CDC's efforts for viral hepatitis that are already funded and how that is predicted to continue or even increase if funds should be approved. But you already have funding for Hep C elimination even without this plan. Could you discuss that?
Well, I think I would cushion that a little bit. We have federal appropriations for viral hepatitis operations. But I think we've made very clear, at least in CDC's 2025 strategic plan, that existing resources will move us towards our goals. But there's additional investment and removal of barriers is needed for us to meet our 2030 goals. I think just to put in perspective again, the 2030 public health elimination goals are in the context of incremental 2025 goals. And so we're looking to reduce incidence by 90% and related mortality again for B and C by 65% by 2030. The incremental targets for 2025 are in about the 20 to 30% range across most targets. And while we're on progress for some of those targets, we are not on target, for example, with Hep C incidence. Those numbers are actually continuing to go in the wrong direction. And so before we can even start making progress, we're going to need to bend the trajectory and start reducing incidence. Over.
Fantastic. I'd like to change the topic a little bit and move to Dr. Seaman. Dr. Seaman has already answered some of the questions in the Q&A, but I'd like to have him expand on some of that. Specifically, one of the things that you mentioned is the functionality of dried blood spot testing. And I think a lot of people are focused on point of care testing in the future. But could you talk to us about dried blood testing? Specifically, how long does it take you to get the results back and start treatment, and other specific aspects of that you could inform us on?
Yeah, sure. Thank you. Yeah, I think both point of care confirmatory testing is necessary. Both point of care and dried blood spot are necessary. I think they kind of serve different purposes. Dried blood spot takes about 3 to 5 days on average to come back for us right now, and that's come down. I think if you were to scale it further, it could be faster as well. I think the real benefits of dried blood spot are very low tech in the field. It's just a piece of paper. You don't have to haul around a big machine. I think that the other benefit is that while you can get, for one of the point of care testing modalities, you can get hepatitis B surface antigen cartridges, but it's a whole other test and it has more cost associated with it. And I think for me, and I think most providers, I'm willing to treat people with a very slimmed down laboratory panel, but I do want to see their hepatitis B surface antigen because of the risk of reactivation. So I think with what we can do with dried blood spot, we can do Hep C RNA, Hep B surface antigen, and Hep B core on a similar system called serum separator cards, which for me is they're ready to go for the vast majority of folks that we treat. We can treat with just that information alone.
Fantastic. So you touched on multiple aspects of dried blood spot testing that I think can be more widely implemented. So thank you for that. In terms of paying participants, Dr. Seaman, do you see this as necessary going forward, or do you think it's necessary now as processes are being developed to address these difficult or in-need populations?
Incentives are really interesting. I think that it really depends. So we were doing some qualitative studies on our incentive program right now. And what we found is that, there are a lot of people who the incentive didn't really mean anything. It was nice, it was great, I got some money, I got to pay for some gas to get down to the lab or something, but they didn't need it. They were intrinsically motivated. And there are other people who absolutely, the reason they got tested is because of the incentive. And we also use referral incentives. So for people who want to refer others into treatment in certain settings, we will pay $10 per person they refer in. And the whole idea there was that, well, if people are getting Hep C through their community network, injection networks, then if we can kind of walk back through those injection networks, potentially we could get more people directly into care. And that hasn't worked as well. And I think some of it has to do with how and when we're offering those, which would be, I think what we're finding is that in the middle of treatment, when people are really inspired, if you can target people, hey, who do you know who has Hep C? I think we will probably be more successful. As far as your specific question, I think that they are a helpful additive and they are probably necessary for certain groups of folks. And I think they're very helpful for the SVR12 lab time point in people who have a lot of competing interests. If they can get that, if we're telling people they have like a 99% chance of cure if they take their meds. So people are like, well, I took all my meds, I'm going to be cured. So convincing people to come back so we can be sure, especially later on in the elimination modeling, getting everyone to get cured for those rare reinfections or those rare treatment failures, I think will be really important.
Fantastic. I'd like to transition to Dr. Momin. Thank you for that update on efforts from the very successful cancer prevention programs. I mean, we saw the decrease in cancer mortality. And I know that there's been success in addressing other oncogenic viruses like human papillomavirus. So Dr. Momin, can you talk about some of the previous successes with HPV and some of the expectations of how the cancer prevention programs are really going to synergize with established programs at the CDC and other programs that are more infectious disease based?
Sure. So the National Comprehensive Cancer Control Program, as I mentioned, funds all U.S. states, DC, tribes, and territories. And we're actually celebrating our 25th anniversary. HPV and cervical cancer screening has been a key component for us. We have an entire group of scientists and team dedicated to specifically HPV. There's an entire national roundtable that's works towards HPV and cervical cancer screening. So I don't want to speak too much on the work in HPV. Of course, our goal is, to increase screening to 80% nationwide. And so there's definitely many interventions that are being implemented in our program related to HPV. A lot of the work that I've been engaged in has been really to incorporate some of the HBV and HCV efforts in terms of identifying or supporting liver cancer prevention efforts. We do have a comprehensive cancer control national partnership, and we do have a vaccine preventable cancers work group that leads that, and I serve as the co-chair of the HBV piece. And then there is a co-chair for HPV. So I think what we're trying to do, Dr. Thomas, is take some of the best practices within, HPV, which has really been a core of what our programs are engaged in, and then incorporate HBV and HCV. But I think I'd like to ask Katie. I mean, I know Iowa has been involved in a lot of HPV efforts, and so Katie serves as the manager of the Iowa Department of Health, and you can speak to some of those examples within the state of Iowa, specifically for HPV.
Yes, yeah, in Iowa, it's definitely an especially big concern in Iowa because we have the #1 highest incidence rate of oral cavity and pharynx cancers, which is linked. Some forms are linked to HPV, some are linked to alcohol, tobacco. There's other risk factors, but alcohol also, shares a risk factor for liver cancer. So we're trying to get more into alcohol as well. But for HPV specifically, the focus is really on adolescents completing the HPV series. And the big evidence-based intervention that we focus on for that is a strong provider recommendation. So it's called the announcement approach or the presumptive approach. And it's basically having providers of adolescents say, your adolescent is due for 3 vaccines today, and sandwiching HPV within the other 2 that are recommended at that age group. So it's a very tailored evidence-based intervention for HPV. But I do agree there's a lot of lessons to be learned that extend with hepatitis B vaccination as well. And there's a lot of kind of all vaccines trying to increase vaccination rates and combat vaccine hesitancy and vaccine information that can apply to Hep B as well. And I also want to plug that the comp cancer programs have cancer plans for their states or their territory or jurisdiction. And I know for us, we have a vaccine part of our plan, which includes hepatitis B in addition to HPV. And then we also have hepatitis C screening and treatment as part of our cancer plan as well. So that's another resource that's available. And there's definitely more that comp cancer programs can be doing to be involved in liver cancer prevention.
Fantastic, Katie. I'm going to have you end off the webinar. We have about a minute left, but there's several questions about states with limited resources. And we know the departments of health in every state contribute to a lot of these programs we've talked about. Can you give any parting advice to states that are just resource limiting? They don't have any FTEs for viral hepatitis, and how you would suggest for them to get programs moving?
Yeah, I know we're at time, so I won't have much time to answer that. But I think feel free to email me and I can connect you with our Hep C folks at the state. I think a lot of it is using the dollars you have to try to also include, the Hep C messaging, or for example, getting your comp cancer program to be more involved, reaching out to your cancer coalitions. Every comp cancer program has a cancer coalition. They might have ways of kind of stretching that dollar, or, having volunteers who might be able to help more, linking up the liver cancer prevention efforts and Hep C efforts with, other related efforts as well, I think could really help. But it's hard, and it's hard when there's not enough funding to really fund a staff person, for example.
I think the only thing that I would add, and I typed it in the Q&A, is that there's also funding for viral hepatitis prevention and surveillance. And clearly we would love to see that expand as well as part of the National Elimination Initiative. But in 2020, fiscal year 21, 59 state and local health departments at least received what we see as kind of base or beginning funding in each of those areas in order to get FTEs and people on the ground to start working with their counterparts in other health department programs. So obviously we hope to be able to expand that, but it's a starting point for a national coverage. Thank you.
Thank you all so much. I would like to thank Dr. Thomas for moderating today, for a great conversation, and to all of our presenters who were fantastic. One of the questions that came through was, will we share the slides? The presenters have agreed that we can share the slides. So we will email the slides out to the attendees next week with a link to this recording. So if you'd like to go back and watch it or share it. I will also like to thank the Centers for Disease Control for collaborating with us on this program. We could not have done it without them. Especially, I just would like to give a special thank you to D'Angela Green and her staff for supporting this and helping with everything. And of course, Casey Pender, our program coordinator, for all the behind the scenes work. And thank you all for attending and joining us today. We thank you all.